Yes, yes. Kalajar, once upon a common time, it was common in this subcontinent of the world, and the organism over here is the Leishmania donovani, that is elderly body, and we heard of it. Sandfly is the vector. The promastigate in a mastigate form, they in human cycle, they go on cycling, proliferating, and then transmitting each other, and so incubation period is years. So chronic infection and cellular immune response is defective, and one at one stage when the higher amount of the parasites overwhelm the people's immunity, then you one have the visceral leishmaniasis. Apart from that, there is localized cutaneous leishmaniasis, oriental sore, papule nodule ulcer-like presentation. Diffuse cutaneous leishmaniasis also possible, and disseminated leishmaniasis (DL) is also possible. Mucosal leishmaniasis or spondia is also possible. So, by far the commonest presentation, the clinicians, the pediatricians, they handle with this entity. Once upon a time was very common, and then nowadays still they do exist. So how they do present. The child is usually below 5 years old. It's possible. No age is immune. Asymptomatic, oligosymptomatic possible. 25% of the active kalajar occurs within 2 to 8 months of inoculation. Patient usually have various sorts of fever, commonly high fever, maybe other grades of fever. There can be hepatosplenomegaly, hypersplenism in the long-term cases. Severe cachexia is possible, wasted 3 to 6 months, longer time, and the jaundice, liver involvement, edema, hypoalbuminemia, and pancytopenia, marrow involvement, and anemia with anemic heart failure, bleeding, thrombocytopenic, and epistaxis, all are possible. There can be secondary bacterial infection, and their death untreated cases. Once upon a time it used to happen, 90% of the death was the record, and but treated cases record is 4 to 10%. But nowadays with the advent of the multiple molecule, I think it will be less. And how to diagnose these cases? So you have the endemic region, you have the your CBC, hypoalbuminemia, hypoanemia, platelet count low, WBC count low, that is pancytopenia. Not always, you can have normal count also possible, and your liver involvement, you will have raised ALT, IgG elevation, hypergammaglobulinemia more than 5 gram, mostly IgG, and finally you have the diagnostic test over here is your DAT, differential agglutination test, or ELISA, enzyme linked immunosorbent assay, and detecting the antibody. So and finally confirmation of the for diagnosis, you need to do bone marrow, splenic puncture, and other tissue aspirations like lymph nodes. What do you see over here? You see the amastigotes from the aspirate. Then the yield is quite high, 80%, 60% or so. So combine these two and exclude the differentiants like malaria, you have leukemia, miliary tuberculosis, lymphoma, and other disorders where you do have hepatocellular growth failure, you have anemia, fever for long time. So CBC will guide, and culture. Once upon a time people used to do in NNN medium. We can be done also. So immunochromatographic strep test is also useful. The K39 is said to be diagnostic, 90 to 80% of cases. Sensitivity 95% or so can be done. So how do you treat kalajar or visceral leishmaniasis? Sodium istugluconate 20 milligram per kg per day, IV or IM for 28 days, minimum 3 weeks is the standard and good one, I think, currently throughout the globe. And relapsing cases, you can try the again the same drug, the miltefosine, 3 milligram per kg, below 2 years, 12 years old. Adult dose 50 to 100 milligram per day can be an adjunct or additional therapy. Antifungals like amphotericin B, liposomal amphotericin B, ketoconazole, fluconazole, they are useful at times, but usual practice is to use the sodium istugluconate, and at times a good small amount of time miltefosine. So control of vectors, flies, and the repellents net they are useful in controlling the spread of the Kalajar. Actually, it happened. Now it is decreased significantly, considering the old 50 years, 100 years back.